else. Right on top of the bone graft, you put your first layer of PRF. And this PRF will help with the bone graft healing. On top of the PRF, you get cytoplast, or a collagen membrane, and this will stop the soft tissue from going into my bone graft. And finally, if you have extra PRF, you can put another layer on top of the cytoplast membrane, and this will help with the soft tissue healing, with the gum healing. So if I can, I collect 6 or 8 tubes of blood, and I make several layers of PRF membranes, and I layer it, and the results speak for themselves. I'll show a couple of pictures, you'll see how well it turns out. So we can go from an extraction socket like this, where you don't see any septal bone. There's no septum here, right? You get to placing an implant with enough stability to put a healing abutment on it. And if you wait 3 to 4 months and let biology, Mother Nature, do its job, you have a healed site with an abundance of bone and an abundance of keratinized tissue, both vertically and horizontally. Because we have recent research, last 3, 4, 5 years, that thick layer of keratinized tissue, 2 millimeters or more, both horizontally and vertically, is crucial for long-term implant success and to minimize any peri-implantitis. So if you see a patient like this, when you do a restoration, you can go sleep home comfortably. You know that even if they're not brushing their teeth every day, that implant is probably going to be okay for a few years. So I'll switch to case presentations. I'm going to show you 2 cases. Of course, time is limited. I would have loved to, show 20 cases. This first case was a daughter of my friend. And this is how you know you're getting old, when your friend's daughter needs an implant. She had come in with actually pain on the first molar, endodontically treated, and it had a fracture, subgingivally, close to the level of the bone. And this was causing the pain. Interestingly enough, the second molar that has a large endodontic lesion was not hurting. We did offer her to keep this tooth because, of course, the sinus is here. I'm going to lose a lot of bone volume if I remove both teeth. But unfortunately, because of financial reasons, she could not save that tooth. She elected to remove both and replace the first molar for now. So the first molar was removed. This is a freehand case. It was done same day. Patient walked in, consultation, treatment plan, proceed with treatment. The final drill for this one was a 4.0. 2 millimeters of undersizing because it's posterior maxilla, it's close to the sinus, and it's an immediate case. If I drill to a 6.0 or a 5.5, this implant would spin. I would have 0 torque. But by doing the undersizing, you're able to achieve a high torque and great ISQs. That's why I felt comfortable even placing a healing abutment on this case. Immediately, same day, to minimize any more surgical interventions. The rest of the area is bone grafted, and because we're only entering the sinus by about 1 to 2 millimeters, we call it a sinus bump. You do not need to lift the membrane, you do not need to put bone graft. Safe procedure. As long as you have stoppers on your drills and you go carefully, incrementally, this is extremely safe. More than 2 millimeters, I probably would do some lifting. So patient comes in 2 weeks. The area is healing well. You can see some bone graft particles actually in the tissue. Even if they do not integrate with the bone, they will make your tissue better. They'll make your tissue thicker, which is what we want. And if you wait about 4 months, same result. You get nice, thick tissue, you have an abundance of bone, and I'm comfortably sleeping knowing that this implant will be protected for a long time, because good amount of keratinized tissue will